Hello, everyone. This is Sharina Hagans with the National Center for Medical Legal Partnership, and I would like to welcome you to the Social Determinants of Health Academy. This is our third training in the series, and our topic today is Pathways to Cross-Sector Partnerships. If you're interested in learning more about the remaining sessions, please check out our SDOH Academy homepage for more information. I'll go ahead and pop that in the chat box in a second. In just a moment, I'll turn this presentation over to my colleagues on the panel today, but first I have a few housekeeping items to address. If there are any technical difficulties, please note that the training is being recorded and will be sent to participants after the session concludes. We have a large number of participants on this session, so you are all muted and will remain muted throughout the whole entire duration of our content today. You will be able to ask any questions that you have to our panelists in the questions panel that you'll see on your webinar platform. So if at any time during the session today you have a question, type it in there and all the questions will be directed to me. And if they're TA related, I'll answer those to the best of my ability. And if it's content related, we'll hold those questions until the end for the panelists to answer. We'll have some additional time today at the end of the webinar to do more question and answers and more focused facilitated questions as well. Next slide. And as I stated again, this is our third session in our SDOH Academy series. These are just our goals and objectives for you to get some more background on that. Next slide. And these are our faculty organizations that have been doing this coordinated series with us. Next slide. And to get us started, today's session, again, is Pathways to Cross-Sector Partnerships. We are joined by several organizations today. We have a really lively panel, and we're really looking forward to having them start. We have Liz Buck from CSH, Corporation for Supportive Housing, Frances Isbell from Healthcare for the Homeless Houston, Darlene Jenkins from National Healthcare for the Homeless Council, and Laura Samnata from Heartland Alliance Health, and Elizabeth Murphy from the same organization, Heartland Alliance Health. All of our slides today are available in PDF format on the handouts portion of your webinar platform, so you can download those PDFs and follow along with us today. And without further ado, I'm going to go ahead and pass it over to our first panelist, Liz Buck. Liz?
Thank you so much, Sharina. Next slide, Caitlin. So I want to ground us in some of the work we've already done and let you know where we're headed. So the first session was really about assessing readiness to incorporate social determinants of health. So we talked about the culture and the financial operations within a health center in developing an intervention for social determinants of health. The second session really talked about how are you screening for social determinants of health and how are enabling services allowing you to address non-medical needs of your patient population. And this session today is really building off of that. We know that you're beginning to measure, and we're at various stages in measuring social determinants of health. So how can you be properly linking to community-based organizations to address the non-medical needs of your patient population? So next slide. So we want to give you a snapshot of the learning objectives here today. So by the end of the webinar, we're hoping that you're able to define food security, identify promising practices for building cross-sector partnerships to address both the housing and nutritional needs of vulnerable populations, and particularly addressing chronic conditions and diabetes within these partnerships. And then describing how the lack of access to safe housing and proper nutrition impacts the quality of care provided and diabetes management. Next slide. So again, Sharina went through a little bit of the agenda, but today we really wanted to have your peers share about some of the cross-sector partnerships that they've developed. So I'll start out with a frame about what we've learned in terms of developing and thinking through developing partnerships. We'll hear from Frances Isbell, who's developed a really innovative model in Houston, and she's at Healthcare for the Homeless in Houston. We'll hear about particularly addressing food insecurity within your health center. So Darlene Jenkins from the National Healthcare for the Homeless Council will tee that up, and we'll be joined by Laura Sumnata and Elizabeth Murphy at Heartland Alliance Health. That's also developed some great innovative partnerships related to addressing food insecurity. We're going to have some time both for facilitated Q&A to dig a little bit deeper into these interventions, and then we're going to have ample time for open Q&A, as Sharina discussed. So we encourage you to keep asking questions. Put them in the chat box. We're going to have lots of time, but as you're thinking of it, feel free to just put it in that chat box. Next slide. So I'll dig in here into kind of addressing that social determinant of health, and so really addressing housing and housing instability with your patient population. So I think thinking through your partnerships, it's helpful to define sort of who you are and who you're thinking about in terms of partnering. So for this example, we're going to dig in a little bit into who a supportive housing provider is, and we're going to think through some of those steps and considerations for partnering. So this kind of example can be applied to different types of cross-sector partnerships. So we want to start out by defining that supportive housing is affordable housing without a time limit that offers voluntary supportive services that focus on stabilizing vulnerable individuals in a community. And for really effective partnerships that we found, there needs to be sort of a mutual gain in the partnership, and that it's sort of mutually beneficial, and that both partners are really fully collaborating. Next slide. And so this is a tool. I'm going to put it in the chat box right now that CSH has created. And sending that, and we'll go to sort of the broader group. So this is a tool that we created in terms of better understanding what health centers need and how supportive housing providers can help. So, for example, this is, not an exhaustive list, but certainly health centers are really interested in providing enabling services, either through direct established arrangements and referrals. And health centers can often, supportive housing providers can often be great partners here because they have qualified staff who can begin to partner and reach that target population in terms of housing. Next slide. And digging into this tool a little bit further, we know what housing providers need. So often housing providers aren't direct healthcare workers, and often recognize that their vulnerable and complex populations need access to healthcare services. So health centers can help and often be a conduit for engagement into services. It can be another area that health centers can provide services and meet really vulnerable populations where they're at. So doing something similar, regardless of type of partnership, can be really helpful in terms of understanding what you need to get out of a health partnership, and then how another partner might be able to help you there. And so kind of continuing on, where to look. So, in order to get started with a partnership, it's helpful to identify who those partners are. And if you follow in the partnership guide link, you can go through all the steps. This is just a snapshot. But it's useful to think through who on your board may have connections to community partners, whether it be a supportive housing provider, a food pantry, another organization. What do you have within your existing network? Really helpful to keep it local as well. So often it can be really overwhelming to have to address all of the social needs within a health center. So there are local organizations that are addressing these issues and often really doing some searches about who they are and how they might have aligning missions can be really helpful in terms of identifying partners that understand your community and patient population. Understanding client overlap is really helpful. So often there could be folks that are in supportive housing units that are going to your health centers, and how do you enhance those services? So it might be helpful to think through where are you already doing referrals and how can those linkages be strengthened. And then complementary services. So it's really helpful to, when you're assessing what your patient population looks like and your overall population in terms of social determinants needs, what are the gaps? What are the gaps that you're seeing in services, and who are then the partners that can help fill those gaps? And next slide. So these are just some options for how you might approach partners. So if you've done this analysis and you've just gotten started and you know that there's a partner that you'd think would be great for a specific project you're interested, certainly a one-on-one meeting can be helpful in terms of vetting that partnership. Multi-organizational meetings can be really helpful if you see maybe multiple needs for different partners and are doing maybe broader geographic-based population health initiatives. So thinking through how that could be a broader collaborative strategy. On the housing side, continuum of care across the country are sort of local bodies that are addressing homelessness at a system level. So certainly if you're interested in better understanding overall housing resources and opportunities to influence that discussion, that's another great avenue for you as well. In addition, we are all sort of NCAs, National Cooperative Agreements, as faculty, and so often we can serve a role in terms of third-party facilitation in building these partnerships. So certainly we have our emails, and if you are interested in developing some of these partnerships, we're happy to help. And so without further ado, I want to introduce our panelist, Frances Isbell, CEO of Healthcare for the Homeless in Houston, to talk about her really effective health and housing partnership. Isabel?
Good afternoon, everyone, and thank you for joining us. Next slide. So what we're going to do first is just kind of go over a general overview of Healthcare for the Homeless Houston. We are about 20 years old and were first deemed a federally qualified health center in 2002, and then another site later in 2007. We are a special population FQHC, so our target population are people experiencing homelessness or people who are very vulnerably housed. One of the things that we did, we have a long history, and I think most Healthcare for the Homeless centers have histories of being very much so a part of a larger community of providers. And one of the things that we did in terms of really trying to connect with the larger community is that in 2011, we began to share a single patient record with our local public health facility and hospital system. And we started out very small, as many organizations do. So in '99, we were seeing about 2,000 people a year, and now we see close to 10,000 people a year. Next slide. So these are all of our, or at least an overview of most of our services. We have 3 different clinics, one standalone clinic, and the other 2 are embedded in other service agencies. Well, we provide really integrated primary and behavioral health care, and we're actually, I don't know if deemed is the right word, but we have reached level 6 integration, SAMHSA's level 6 integration of behavioral and primary health care, something that we're really proud of because it's very difficult to reach. We provide street medicine and medicine in other outreach services. We have a 6-operatory dental clinic, vision assistants. We have a jail in-reach project where we go into the jails, our case managers go into the jail, working with people who are were homeless before they went into the jail and have a mental illness, so that then they are released to our care and we're able to provide continuity care as well. We have an in-reach project into local hospitals. And then the project that I'm really going to be talking about today is predominantly the Integrated Care for the Chronically Homeless Initiative. This is a program that is funded through a Medicaid 1115 waiver. And the focus is people who have 4 or more emergency department visits within the last 2 years and are chronically homeless. And we have another similar program. It's a much younger program, though, that the target population are people who are chronically homeless and have 3 or more convictions within the Harris County Jail, and incarcerations within the Harris County Jail in the last 2 years. Next slide. So part of what I've been asked to do is to talk about the this project that includes a federally qualified health center. It includes a housing provider, and then another agency that provides clinical case management, and we subcontract for those services. So the 3 agencies came together to design and then develop and implement this program. One of the things that the provider from Search talks about, the other name of the provider with case management is Search Homeless Services. And my main kind of colleague at Search talks over and over about the fact that she believes that one part of why this has been a really successful partnership is that we have all known each other for quite some time. We actually grew up and started in the Search Day Center. And we've collaborated on a lot of other projects before and have a real dedication to research, to evaluate, program evaluation, evidence-based practices, etc. Pardon me. And she sees the fact that we had this long relationship, probably for 17 or 18 years before we even started trying to work on this relationship, because it was not necessarily smooth sailing at the beginning. Next slide. So the program itself, it was designed to be a clinical model that linked on-site services with our clinics. So the part of what we provide is nursing and care coordination. You'll see the staffing model in just a minute. So both our nurses and our community health workers are involved in care coordination. We use all of the staff are trained in motivational interviewing, brief interventions, and cognitive behavioral therapy. We provide group therapy, both substance use therapy, kind of more traditional therapy. We have groups for people that are coming directly from the streets, and it's really kind of daily living groups where it's not necessarily a therapeutic group, but it's more how do you adjust coming from the streets and now living in a home? What are the kinds of issues that become challenging? And many of you, if you've worked with this population, have heard stories and know people who came in off the streets and then didn't sleep in their bed for maybe a month or so because it was just so unfamiliar. They wound up sleeping on the floor again. So there's a lot of issues that are really just kind of social issues and not necessarily really deep therapeutic issues. We also have trauma-informed groups and seeking safety groups. We have a model that we initiated in our clinics called Primary Care Behavioral Health Consultation, and this is what moved us into Level 6 integration. In that model, our psychiatrists, our psychologists, our other behavioral health clinicians, They don't even have offices. They provide care directly in the primary care so that those providers wind up being seen as just part of a primary care visit. Let's see, and then, I'm sorry, I'm looking at the slide itself. And then again, our community health workers assist in helping people manage their health needs, including care coordination. If someone needs assistance that requires them going with an appointment, making those appointments, following up about those appointments, etc., then that's what the community health worker is responsible for. Next slide. So in addition to the services that Healthcare for the Homeless provides, both on-site and within the clinics, SEARCH, as I said, we subcontract them for clinical case management. They work very closely in terms with our coordinated access, working with people and helping to navigate someone coming through that coordinated access system into this program and into housing. They conduct the initial assessments and all of the follow-up assessments, and we'll talk about some of those assessments in just a minute. And then they provide ongoing clinical case management, which is different from the kind of case management that we provide in the clinics, which is mostly what you would think of as medical case management. So they're clinicians. The housing provider is New Hope Housing. This is, they're not like a commercial property. Their property is specifically for either people who are experiencing homelessness or people who are very vulnerable to homelessness. So they're opening 2 new facilities in just a couple of months. So I think they have probably around 8 facilities now that are anywhere between 50 units to 150 units. So they're a large housing provider for our community. Let's see, part of what they were willing to do is to participate in this project. And this was a big stretch for them because the target population are people who are chronically homeless, so they have a disabling condition. We also people who have a diagnosed serious mental illness and have had serious medical problems. So this is kind of a new targeted population for them, and it was, like I said, it was a big stretch for them. Next slide. So the team that is on site includes an RN case manager, a part-time director of social services, a lead, team lead, again part-time, 2 community health workers, a part-time behavioral health worker, also a part-time, it's not on here, part-time substance use worker, substance use counselor, and then the primary care team in the clinics as needed. And this is per about 60 clients. So the clients are going to be in varying degrees of need. So we have different levels. Someone who is in the highest acuity of need then is going to have, a lot of very intense services, down to someone who has a much lower acuity of need. So there's about kind of 3 levels, and so combined with all those levels, this team would have about 60 people. Next slide. So one of the things, like I said earlier, that both SEARCH and HHH have been very committed to is some pretty stringent evaluation. The evaluation that we chose for this program is called the SF-36. It's the Social Functioning 36. This is actually a sort of a health quality of life survey instrument. It's been validated within a homeless population, and so what it does, it looks at both someone's health status, both physical health and mental health. And there are 8 domains, 4 physical, 4 mental. And it really talks about the functional, the kind of the functionality of someone that's participating in the program. One of the things that we are much more interested in rather than diagnoses, although obviously diagnoses are critically important, but we're really much more interested in someone's functional level, regardless of what that diagnosis might be, whether or not it's diabetes or hypertension or schizophrenia, bipolar disorder, etc. Our goal is to try to help somebody function in their daily living to their highest ability. And so this SF36 helps to try to quantify that. One of the things we saw was at 6 months, there was very little movement. At 12 months, we began to see some fairly significant improvement. At 18 months, that improvement slipped, and we're not real sure why, but this has happened over and over again. But by 2 years, we began to see statistical improvement in all but one area, and that area is in pain management. The PHQ-9 is really not a survey instrument. It's a screening tool, and it looks at depression, and so we use that as kind of a monitor for us. Reduced emergency department visits, and then with the other program, reduced recidivism in the jail. At the end of 2 years, what we saw, depending on, there's a couple of different levels. One level, we saw an 82% reduction in emergency department visits. One gentleman came into the program with 122 emergency department visits 2 years prior to entering the program, and 2 years post entering the program, he had 12 emergency department visits. So we've seen in one cohort an 82% reduction, in another cohort about a 65% reduction in emergency department visits. We look at the standard FQHC health status indicators, and then we look at stabilized housing and increased income. Next slide. So I want to talk a little bit about some of the early lessons learned, and then we'll pass it on to the next person. One thing that I often say when I talk about this program is it took us about a year of meeting with a representative from the Corporation for Supportive Housing, a search representative, a representative from the housing provider, New Hope Housing, and HHH as we designed this program. And I will talk about, and so does this other woman, talk about the fact that I, in all of my years of my professional career, probably have never argued with anyone as much as I argued with the woman from Corporation for Supportive Housing. And that really had to do with the fact that we speak often, we speak 2 different languages. Something may mean something entirely different in kind of the medical world that it means in the social services world. And so it took a long time for us to try to work through some of those kinds of things. The other thing is that unfortunately some of HRSA's criteria and regulations and HUD's regulations are not compatible. And some things that are going to look really good in terms of HUD reporting is not going to necessarily look good for HRSA and vice versa. And so there's a lot of discussion that has to take place in order to work through many of those issues. And we didn't expect those issues, so those came out as we were beginning to design the program itself. Another early lesson learned was that the RN position, the RN case manager, was truly a critical position. And interestingly, it was the last position that we added. But the RN is able to translate for housing and social service people what's going on within the clinic, and also the vice versa as well. For the people that are in the clinic, they can help translate what's going on with someone's life in their, in the housing, in their unit and in the program itself. One thing that was very surprising to us, and a lot of the literature talks about once someone goes into housing, that often if they have a serious mental illness, and of course that was the population that we had targeted, that it is not unusual for the mental illness to get worse before it gets better. The other thing that we didn't find in the literature is that that's also true of physical illness. Often the physical illness will get worse before it gets better. And so that needs to be considered as you're developing a model. Certainly we had all of the staff have deepened their skills and understanding of other disciplines. The housing provider, I will say, was hesitant. Like I said, this was a big leap for them. And we wound up having to spend a lot of time with the housing providers because often they didn't understand when we would say, they wanted to know what was going on with John Doe and he's acting strange and what's happening. And the staff would wind up saying, we really can't talk to you about that. And so we found a way to have language to talk with each other without violating HIPAA or any of the privacy rules. We also wound up doing a lot of training and have brought in trainers that and always included the housing provider staff. And that has been really helpful. We speak more of a common language now than we did in the beginning. And they really, I think, understand our clients much better and are very appreciative of that kind of training. So we were fortunate that we had this idea fairly early on that it would be helpful for them to attend the clinical training as well. And then the last thing is that replicating this model, there's a lot of funding challenges. People talk about, how rich the staffing is, and that's certainly true. Most programs don't have that kind of rich staffing. Texas did not expand Medicaid, so this is not these services are not covered under our Medicaid service department. And I've been in, one of the good things is that I've been in conversations and in planning with our area Medicaid managed care organizations. And we are going together to the legislature in our next legislative session, working with the Texas Department of Health and Human Services to ask for the legislators to actually begin to include these services in the Medicaid package. So hopefully that's a way that we'll be able to sustain this once the Medicaid 1115 waiver goes away in 2020. And now I'm going to hand it over to our next presenter.
Great. Thank you, Frances. I really appreciate it, and I know we all appreciated the very informative presentation that you gave. This is Darlene Jenkins. I'm with the National Healthcare for the Homeless Council, and we're now going to move in focusing on our second social determinant of health, which is food security. Next slide, please. As we started putting our slides together and identifying our presenters, I thought about, we work very closely to the Corporation for Supportive Housing, CSH, and I thought about just how focusing on housing as well as food security brought me back to just a basic psychology that we had in high school. And I thought about Maslow's hierarchy of needs and how the physiological needs of actually breathing or having air, food, water, and shelter, clothing, and sleep are those basic needs, and how an individual, they're calling that the lowest levels are the deficiency needs, because a person doesn't feel anything if they are met, let me get this straight. They're called deficiency needs because a person does not feel anything if they are met, but becomes anxious if they are not met. So we are dealing many times with populations who have both do not have shelter nor food. And so we know that because these two basic needs are not met, they feel much anxiety around this. Next slide, please. As we talk about food security, we want to make sure that we are identifying or looking beyond just making sure that a person has food. Food security is just more than having access. It is actually having enough food that meets one's needs, as well as ensuring the quality of the food that one consumes is adequate for that need. And we'll see as we go along farther in our presentation, especially when we're focusing on individuals who have diabetes, we want to make sure that they have enough food to meet their needs and to help their blood sugar control, but also that they're eating quality foods. Many times in America, we hear that we are an overfed but undernourished society because many times the quality of our food is not the best. And so as we move into our conversation regarding food security, please keep in mind that it's beyond just having access, but it's having enough food as well as looking at the quality. So now I'd like to introduce our presenters on food security. Next slide, please. Laura Samnada, I'm sorry, Laura, I butchered your name and I have been practicing all afternoon. Laura is a registered and licensed dietitian, and she is a manager for the food and nutrition programs at Heartland Alliance in Chicago. Laura holds a Master's of Science in Nutritional Sciences from Iowa University. She leads a team of dietitians who are providing medical nutrition therapy to individuals and group education to people living with HIV/AIDS and to people who are homeless living with a mental illness. Our second speaker is Elizabeth Murphy. She is originally from Chicago and she received her bachelor's degree in nutrition and dietetics with a minor in urban poverty studies from St. Louis University in St. Louis. Elizabeth has spent 2 years as an AmeriCorps volunteer in Spokane, Washington, where she found her passion for community nutrition. She completed her dietetic internship at Michigan Medicine before returning to her sweet home, Chicago, to work as a community dietitian. So I'd like to now turn the presentation over to Laura. Thank you.
Thank you so much, Darlene, for that warm introduction. I know my last name's really tricky. But thank you. So as Darlene touched on food security, it is a complex problem, and this diagram demonstrates this nicely. As you can tell, the stress of food insecurity can lead to chronic illness and can keep someone in this cycle of poverty. Next slide, please. Here in Cook County, where the city of Chicago is located, the food insecurity rates are quite high. And that's where we have focused a lot of our services at Heartland Alliance. The red dot that's at the most top is really close to our FQHC building, and that has about a 15 to 22% food insecurity rate, and the dot that's the red dot that's at the closest on the bottom is really close to a second FQHC that we're building and going to open on March 20th, actually. And so we're also looking at really high food insecurity rates near that location in the Inglewood neighborhood as well. We also have several food pantries. That's what the red dots demonstrate on this diagram. And they're available to people who are living with HIV and AIDS. I'm not going to talk too much about those food pantries, but we are doing some unique work in our food pantries. But it is telling that our food pantries, they're part of a safety net or the emergency food system. Next slide, please. So this diagram is a continuum of care for food and nutrition services. And as you can see on the left, food banks, pantries, soup kitchens, they're all sort of a part of a prevention program. But we also know that many of the participants that we work with and see are living with chronic illnesses such as diabetes. So we're trying to move our food and nutrition programs and integrate them into medical care and the treatment plans of our participants in both our primary care as well as our behavioral health services. So we're beginning to offer medically tailored food to help with the treatment of someone's chronic disease. Next slide. So this is just a brief introduction about our organization, Heartland Alliance. We've been serving participants for over 125 years. Specifically, my and Elizabeth's work is in the healthcare branch of Heartland Alliance Health. Our FQHC, we provide outreach, primary and behavioral health care. And then we also have a strong food and nutrition program that sort of intertwines all of those other services that are provided. And so our dietitian, Elizabeth, who you'll hear from soon, she provides medical nutrition therapy and group education with cooking demonstrations. Oh, sorry, next slide, please. So just talking a little bit more about our food and nutrition program. So Elizabeth is our dietitian in the clinic, but our team also believes that food is medicine. And so we developed an anti-hunger team based on that our staff were discussing ways that they were seeing our participants struggling with food security in our waiting rooms. And so we decided to develop our anti-hunger team. And we're starting with some small projects to help our participants with their food security. We're hoping to build to something larger as well. But currently we're providing oranges and bananas and healthy granola bars, as well as peanut butter sandwiches in our waiting rooms. We just put it in a basket at the front desk and people can come pick as they need any food. And later this year, we're hoping to open a food pantry in the clinic, but we've discovered that space is an issue. And so we're gonna partner with our local food bank called the Greater Chicago Food Depository, and we're going to offer a mobile pantry, which will park right outside of our clinic once a week and be open for a couple hours once a week, where the eligibility criteria will be that providers will write a prescription for fruits and vegetables, and then these participants will have priority for the fresh fruits and vegetables served out of the mobile pantry. And then on the bottom of the slide here, we're talking about the hunger vital sign, or the 2-question food security screening, to help us find those participants that are food insecure right in our medical clinic. Next slide, please. This tool was really helpful in helping us think through how, when, and who would ask the 2 questions. There's also a nice toolkit that Feeding America put together that I'm happy to send later if needed. But we embedded these questions into our electronic health record. And so our MAs are asking these questions and identifying if their answer is often true or sometimes true to either of those 2 questions. Then a patient is food insecure, and they'll either help link them to other food pantries or soup kitchens in the neighborhood. Elizabeth put together a wonderful resource of the food pantries and soup kitchens in the area. But we're also, following up with the participants to make a referral to talk to Elizabeth about how to shop on a budget or how to best utilize the SNAP dollars that they might have. And then also just connecting, making sure all the providers know that this patient identified as food insecure, and so these are the things that we're trying to help them with. So, and just so everybody's on board as a team to help this participant with food. Next slide, please. So Elizabeth and I are also, we felt that to best connect our participants to food and make recommendations on the food that they have access to, we needed to understand what resources our participants had So Elizabeth and I started surveying our surroundings around the clinic. So we're currently in a sort of an assessment phase, and we are talking to the food pantries and the hot meal sites. And then when the farmers markets start, we'll hopefully go visit those as well. But the people we have talked to, they're excited to have our dietitians come and visit and make recommendations on the food that they're serving. And we're going to offer lunch and learns about, maybe the chronic diseases that our participants are dealing with, like a diabetes 101 class or hypertension, so that they can learn why we are making the recommendations that we do in a session with a participant, so that when the participant goes and visits the food pantry or hot meal site, that they would be able to choose the foods that fit within that chronic disease treatment plan. And then throughout this whole process, we've been partnering with the Greater Chicago Food Depository, which is Chicago's food bank. And then recently we developed a relationship with Whole Foods. And they've really helped us sort of learn about our other neighbors and our community, and also help us market our services. So a couple weeks ago, we went to Whole Foods and we set up a table and just talked. We were open to the grocery store customers, and they came into our table and talked to us about the services we provide. And then we did a cooking demonstration as well, and had a little question and answer session. And it went over really well. Whole Foods also helped us with a fundraiser during that time. So that's always helpful to have a little extra funding. But these are just a few of the ways that we've partnered with other organizations, but there's a lot of other ways to connect with community gardens or farmers or local food rescue organizations. We're also trying to incorporate our work around food and nutrition with our Medicaid managed care organizations, like Francis was talking about. And we are hopeful that our MCOs can help reimburse for food and nutrition services. And they have shown interest, and we're really looking to explore that relationship deeper. So that's all I had. I will pass the baton on to Elizabeth.
Thanks, Laura. So Laura had already mentioned the 2 hunger vital signs questions, but these are specifically what they are, and we incorporate them into our participants' visits with providers. So did you worry whether your food would run out before you got money to buy more, or was there a time when the food you bought didn't last and you didn't have money to get more? So some of the questions that I ask when I'm in a visit with a participant would be, where do you get most of your food from, whether that's a food pantry or soup kitchen, discount grocery store, fast food restaurant, or corner store. And as Laura mentioned, we try and visit those places that participants tell us they frequent. And I've learned about which places let you choose different options for food at soup kitchens, or which pantries tend to have more fresh produce available. I've also made it a point to visit the different corner stores, dollar stores, and discount grocery stores in the neighborhood so that I know what's available there, and even sometimes taking pictures at the store so that I can show participants, if they're interested in making an alternative choice when they go shopping, exactly what it looks like and where they could find it. So another question we'll ask is, do you receive food stamps or SNAP or LINK? And most of our participants do, but if they say no, then we can refer them to our benefits program so that they are able to access that resource if possible. Do you do your own cooking or grocery shopping is an important question. I mean, in other settings, we would probably assume participants have access to basic kitchen equipment or to grocery stores, but in this setting, we can't really make that assumption. And even something such as Tupperware or a knife and cutting board, a can opener can be really hard for participants to purchase if they are unstably housed or doubled up or not in a space where that's available to them. Next slide, please. So the picture on the right is from our cooking demonstration that Laura mentioned at Whole Foods. I just really enjoyed that, so I wanted to include it. But the case study is about a different participant. He is not pictured. And the case study is specific to type 2 diabetes because Darlene mentioned that we would want to talk about that. So I saw this participant. He was referred by his primary care physician for type 2 diabetes education. And I saw him about 1 week after he was diagnosed. And he was diagnosed while he was hospitalized at a nearby hospital. And he wasn't really seen in our clinic regularly until right before his diagnosis. So he's obese. He stays in a storage unit and does not have a place to store or prepare his food. He does work part-time, and he has access to a refrigerator and microwave while he's at work. And at the time that I saw him, his hemoglobin A1C was 13.4, but he had just been diagnosed and just started taking medication to control his diabetes. One of the moments where I stopped, every session I'll ask somebody, do you avoid any certain foods or drinks? And this participant said, yes, everything. And so he was, in the week prior to seeing him, he was spending $14 on salads from the grocery store until his food stamp money ran out. And he was expressing to me his concern between paying his storage unit bill, which was due that Friday, or having to buy salad from the grocery store because he thought that was the only thing that he could eat. So we ended up talking through his food choices and different options that were available to him, more so discussing the fear that he had around eating ever since his diagnosis. And we were able to set some realistic goals for him and help him realize that he would be able to pay for his storage unit bill, and he would also be able to find food that was good for him to eat. Next slide. So the image on the right is from the Greater Chicago Food Depository, which Laura mentioned earlier. There are many different food pantries and soup kitchens in the city of Chicago, and many of the goals my participants set revolve around eating or finding food to eat. And so a lot of the realistic goals that we set are related to that. At Heartland, one of our fundamental practices is called harm reduction. So instead of concentrating on eliminating or completely changing a behavior, we like to focus on what behavior our participants feel they want to change or would be able to change. And so these are real goals that I have come up with participants. So harm reduction, putting 5 packets of sugar in coffee instead of 7 is maybe doesn't seem like a lot, but that's what that person was able to do. Or trying to find a place to eat lunch every day, choosing a health alternative option at the soup kitchen, replacing a sugar-sweetened beverage with water, applying for food stamps, and then the last goal, instead of eating 2 sandwiches for lunch, saving 1 sandwich for an afternoon snack is what the participant from the case study came up with for his goal, which I was pretty proud of him. Next slide. Something I love about working in a big city is there are a lot of programs that would benefit our participants. The trick is becoming aware of those community food or community health resources and then connecting those resources to our participants. So I saw when I was riding on public transit one day, the American Diabetes Association has a health and wellness expo that's free and open to the public to try to do some preventative care, make food and wellness exciting and fun. A nearby clinic is partnering with us, allowing us to refer our participants to a Take Charge of Your Health 6-week education program. There's a hospital nearby the clinic that offers free physical activity classes facilitated by an exercise physiologist. And then the Chicago Park District Fitness Prescription Program provides free 3-month memberships at fitness centers for Chicagoans with a doctor's prescription for exercise. So that's another program that I don't necessarily refer people to, but I will help them find a Park District fitness center near them. And then I especially enjoy being able to refer our participants to other providers in our clinic. And we have mental health clinical practitioners who facilitate walking group or happiness group. And I've been to these groups so that I'm able to say that, oh, I've gone on the walking group or I've been to the gentle yoga group, and explain a little bit more about those groups and how they would benefit our participants. That's it.
Great. Thank you so much, Laura and Elizabeth. We're going to now have just some facilitated Q&A, and Frances as well as Liz is going to join us. But I was interested in finding out more about, I think Laura mentioned the medical tailored food. Could you tell us a little more about that?
Sure. Yeah, so this is in our food pantries that serve people who are living with HIV and AIDS. And in our food pantry, we have, we're starting to trial medically tailoring our grocery menus. So we're a food pantry of client choice. Clients get to choose the food that they want. But we are going to start medically tailoring their grocery menus, their options, so that if they present with diabetes or hypertension, renal disease, that they would be presented with a diabetes-friendly or hypertension-friendly grocery menu. And so, like, for example, on a renal disease grocery menu, phosphorus and potassium are foods that clients need to avoid if they're on dialysis. And so we would take those options off the grocery menu that they have available to them, and we're trying to sort of fill in gaps with other options that would work for their chronic illness. Mm-hmm. We're just starting now to get feedback for that, but we're excited to trial it. I know this is already happening in like New York City, and Washington, D.C., Atlanta, San Francisco. There's several organizations in those big cities that are medically tailoring their food. And those organizations also do home delivered groceries. But I know they have specialized chefs that make a hot meal and freeze them, and they're all medically tailored by a registered dietitian.
So do you have any partners that are working with you on this project?
No, we don't. It's just my team of dietitians.
So it's just,
yeah.
Oh, okay. So the dietitians are doing that. Okay.
Yep. Mm-hmm.
Great. As we move, we talked a little bit about person diagnosed with diabetes. So are there any additional, and this is for Laura or Elizabeth, are there any additional suggestions when helping a person who has diabetes, who may have mental health or substance abuse challenges? Do you have any suggestions, just helping them maybe comply better with instructions or helping them to get healthier food options, or you talked a little bit about coming to realistic goals. Are there any suggestions around that?
I guess I would say being persistent. Some of the participants that I see that have serious mental illness, we need to talk about the same thing every time that we meet, but not, I guess, being patient and persistent with that, and really taking care of them in the way that they need.
Great. Okay, thank you so much. Liz, I know you may have a few questions that you need to ask.
Thank you so much. I would love to just, Frances, to dovetail and chat about that as well. Often there are multiple conditions that folks have, so behavioral health needs, substance use, chronic conditions, housing, instability. How do you approach that in your clinical framework and with your partnerships? what do you prioritize over the other, or how do you think about those kind of competing needs and priorities within your care coordination intervention?
I think that can obviously depend on several different factors, especially if someone has a diagnosed mental illness. Are they adherent with their medication? Those kinds of things, and that's going to make a big difference. But I think I would start with the idea that it's really important to know what the client wants. And this is something that we talk about throughout our organization, whether or not it's with our medical provider staff, our behavioral health staff, our community health workers, our medical assistants, everyone in our organization. We talk about starting with the concept of what it is, what is it that the client wants to address? Why are they here? What is their interest? There's kind of an ongoing debate, and has been from the very beginning. If you think about our population, the question that we debate is, who is actually more important, the case manager or the doctor? And I will tell you that the medical staff will almost always say it's the case manager. So, I don't have a really quick answer to that, because I think that with really complex folks, that what is almost essential is trying to establish trust with that person, as well as establish successes. I liked the slide. I think it was try to get somebody to go from 7 packets of sugar to 5 packets of sugar in their coffee or something. So part of trust is helping to assist someone in having a success. So it may be that addressing their diabetes right off the bat is not what we're going to do, because that's not what the patient is interested in. It may be something entirely different. So, I guess my point is, I think that it's a long process, whether or not somebody's still on the streets or whether or not they're domiciled, that it's often a very long process. We do an awful lot of education, as Heartland does too, and I agree with the idea that you have to be patient, and often it's reinforcing small steps, but reinforcing that same small step over and over and over again. And that's part of kind of motivational interviewing and stages of change theory. So this may be kind of a rambling answer, but that's my answer, and I'm sticking to it.
That's beautiful. Darlene, I'm wondering, we have quite a few questions in the chat box. Should we?
Right, yeah. I was just going through them. Yeah, I think we should start on the chat box, because there's quite a few. Sharina, did you need to say anything before we move to the chat box, because we do have quite a few questions here?
Nope, you can go ahead and get started. Thank you so much,
Okay.
Darlene and Liz and everyone.
All right, I'm scrolling up to the top, and I'm just trying to see. Liz, would you like to handle the ones that are for Francis, and then I can ask for,
Yep, that works. I'm happy to get started. So, Francis, there are quite a couple of questions related to this project in partnership. And so, and actually just to your last answer, so one person was asking, do you use a specific worksheet or template to assist patients to identify a goal? When you're talking about addressing patients' goals as sort of a first way to get started, how do you start that? And do you have a template?
We have sort of a template that we have integrated into our electronic health record, there's not like a list of goals, a drop down of list of goals, etc. That would obviously be easy, but it's much more individualized than that. And then one of the things that helped us to achieve level 6 integration is that everybody uses the same a single patient record. So our electronic health record is Epic, and we've been able to make a lot of changes into it so that our primary care clinicians and our behavioral health clinicians and the staff that are off-site in the housing facilities, we all use one single patient record, and in that record there will be one plan of care. And so each department may have a little bit of a different way of addressing the patient goal, but there is one kind of overarching goal that the patient has set. And it may be, let's say, if somebody's still living on the streets, it may be that they come in and what they're really interested in is, let's say, getting a job. And we're not an employment provider, but part of what we will do is to try to help immediately start linking them with our case managers who can link them with other services, et cetera. And at the same time, try to talk to somebody about the fact that their blood sugar is now 250 or something like that. So the answer is a hybrid. We do have a form, but it's not one that's like a drop down or has specific categories, but there is a single plan of care. Am I still on the air?
Oh, I'm so sorry. I was on mute. This is Liz. Okay. So I'll ask you one question, Francis, and then I'll pass it back to Darlene to ask a few questions at Heartland. So this is clarification. I'm sorry if I missed this, but what exactly is the relationship between Healthcare for the Homeless Houston and New Hope Housing? Is the clinic able to place people in New Hope Housing? If so, is Healthcare for the Homeless contracting with New Hope, and is this part or separate from HUD coordinated entry? So
that's all. Yeah, it's all part of the our coordinated access, which is the HUD entry point. They're all vouchers, and our relationship is we have an MOU, and we're collaborating agencies, so they don't pay us for anything, and we don't pay them for anything. We don't have a financial arrangement. We have a programmatic arrangement.
Great. Darlene, do you want to ask a couple questions that came up for Heartland?
Yes. Here is a question regarding, are you documenting that the patient actually went to the food pantry? It says our accountable entity wants us to make sure that happens, but the food pantries in our area do not collect that information. So Laura or Elizabeth, can you answer that? Are you tracking visits, or if they actually make it to the food pantry?
Elizabeth, I'll let you take this one. You see those participants more than I do.
Oh, no, I don't think so. I mean, I'll document something in my own note, but I don't know that it goes elsewhere from there.
Okay, so you're currently not tracking in any methodical way.
Correct.
Okay. Here's another question for Heartland. With the Lunch and Learns about different health issues and their relationship to consumers' food choices, are you creating your own patient materials, or are you using your health partners' educational materials?
Yeah, we're going to use our own materials. Elizabeth and I are going to get together and create some presentations, PowerPoint probably, with some handouts.
But we usually do look at existing materials and then just tailor it to the needs of our participants.
Okay, thank you. Liz, I'll let you do a couple of more, and then we can come back with Heartland. We can alternate that way.
Sounds good. So it gives time for our panelists to take a breather for a question. So, Francis, a couple questions came in about if there was a control group for your evaluation because of considerations for regression to the mean.
So I saw that one. I was hoping you wouldn't choose that one. We do have a control group, but not the way that the question is asked.
Okay.
The control group was so again. The program that I focused most on was funded by an 1115 waiver, a Texas Medicaid 1115 waiver district project. And there was another FQHC that was awarded a smaller contract to try to do the same work. And they had a very different model. It was an interesting kind of interaction because we really did have a lot of learning between the groups. So we had a control group that received a different model, and we are actually getting ready, hopefully, to publish a paper on that. And so I can't really speak a lot to the results of that because it is going to be. We're hoping to get it published. But there was a control group, just a little bit different than the way that they were talking about.
Okay, so stay tuned for that. We should stay tuned for that. And I put something in the, actually Sharina put something in the chat box. So that's our Social Innovation Fund evaluation. So that's actually the first randomized controlled trial evaluating the impact of supportive housing for high users of healthcare services, so really targeting a highly expensive and vulnerable population. And so the results are there, and NYU published them almost hot off the presses about 2 months ago, and it essentially found reductions of usage, but it depended on the site. So, for example, in the sites with a really connected, coordinated health center and available healthcare services, you found more of a reduction in ED uses. I think we would assume because there's a better kind of connection to primary care and behavioral health care in that type of community. So really interesting findings. Happy to share that with all of you, and feel free to reach out to me if you have more questions on that. Darlene, any others for Heartland we want to ask?
Yes, we have a couple more. For Heartland, do you know the nutritionist bill for visits with Medicaid or Medicare? And I'm going to say, instead of nutritionist, registered dietitian.
Yes. Yeah. So in Illinois, we cannot bill Medicaid because we're an FQHC, but we are filling all the paperwork and applying for billing for Medicare.
Okay, great. Thank you. And I'm sorry, go ahead.
Oh, I just said, yeah, no problem.
Okay, all right. And then I think this may be the last question I had to go through, but for Heartland, what organizations do you know in the Washington, D.C. area that are doing medically tailored food? Can you refer us to a website where we can find their type of organizations to partner with?
Yeah, so they are in Washington, D.C., it's called Food and Friends. I was just there last September when I was at the Food as Medicine Coalition Symposium, and I visited their office. It's quite lovely, and I know the dietitians there, so I'm sure they'd be happy to open up a conversation with anyone in the DC area.
Great. So that was Food and Friends. Is that correct?
Yep.
Okay, great. Thank you so much.
Sure.
Liz, I think that's it for Heartland, but there's a few more for Francis I'm seeing here.
Yeah, fabulous. And I love that connection. I feel like we just made a linkage, which is the point of this webinar, which is fabulous. So for Francis, and Francis, this may not be like a 30-second answer. So if we want to send it, additional resources, we're happy to. My clinic is trying to incorporate RN care coordinators into the existing structure of case managers, non-clinical staff. So they're adding RN care managers. How does HCH Houston divide the work between the two? So kind of what is the different role between an RN care coordinator versus a case manager?
It probably would be better if we had the RNs and the case managers and community health workers here to try to talk about that. There's obviously a lot of overlap. Within the clinic setting, our case managers really are providing what you think of as medical case management, referrals, really helping to link somebody to a different service, if somebody needs, ID and those kinds of things, helping them to, get all of that in order, et cetera. On the case managers that are in the permanent supportive housing sites, that's really a different kind of case management. It's much, much more clinically focused. These are all LCSWs, so they have a clinical background, and they're providing really more of a clinical intervention. The RNs are the RNs then are really more kind of focused on health, wellness, and medical kinds of issues, although, like I said, there's so much overlap. But they're much more focused on that kind of real healthcare coordination than they are with the clinical intervention. So since we don't have the other person, I don't know if that answered their question or not, but that's how I would see the difference. Again, there's an awful lot of overlap, though.
No, that's helpful. I'm just scrolling, Darlene, if you're seeing another question that we haven't had answered yet. And feel free to send in questions in the chat box. Okay, so for Frances, is it possible, Frances, for you to comment on the certification for integrating behavioral health into primary care? She was saying they are level 6. I was just wondering what the name title of that certification is. I think I missed it.
I have absolutely no idea. If you go onto SAMHSA's website, they have a publication, and it talks about levels of integration all the way from kind of co-location. There's 6 different levels, and the last level is kind of this. And I don't even remember what the name of the level is right now. I mean, it wouldn't take me long to get it, but I just don't have it right off the tip of my tongue. But it's a level where it is truly integrated, and it includes having an integrated medical record, that behavioral health has now been integrated into primary care. So I apologize. Like I said, I could get it, but I just don't remember it right off the top of my head.
We can definitely follow up in an email with that information too, and send that to the group.
But if I remember right, it's fairly easy to find on SAMHSA's website.
Okay.
Great. Liz, I do see one question that I think it's for Frances, but I think Elizabeth and Laura can also answer this, because it talks about, the question is, what unique health literacy education strategies have you employed as part of the overall model of care for the chronically homeless? So I think everyone could kind of answer that from the portion of just serving within healthcare for the homeless model of care, both in Houston and Chicago. Do either of your places have unique health literacy or education strategies?
This is Frances. I'm going to let the others take the first stab at this.
No.
No. The reason I'm saying that is because, once again, I don't have anything at my fingertips.
Yeah, that's how I feel.
We are very fortunate that we are able to purchase, this sounds awful, but I purchased 30% time of a researcher from the University of Texas School of Public Health. And part of what she does is she helps answer those kinds of questions. For example, early on, about 6 months into the program, we wanted to offer some diabetic programming, and she was able to do a lit search, and we looked at about 6 different programs, wound up choosing one, which of course I do not remember the name of right now, but it showed a lot of progress, not progress, a lot of positive outcomes and promise, a lot of promise. And so we've done this, we've offered that programming several times throughout in the last several years. One of the things I know is that it's really imperative for us to offer incentives. And we had on-site testing so that people were able to really follow, so there was a lot of visual cues, a lot of incentives, but I cannot remember the name of the program that we chose. So I was hoping maybe, Laura or Elizabeth might know a bit more.
I can definitely agree with everything that you said. Offering incentives really helps. I tend to use, I just pulled up a couple handouts that I use. One's developed by Community Health Worker Health Disparities Initiative, also part of the NIH, helped develop that, and then Association of Clinicians for the Underserved have some really good resources on their website as well. And then I tend to use a lot of actually like school nutrition education resources. One of them is called We Can, Ways to Enhance Children's Activity and Nutrition, because again, with the visual aids and the health literacy, it's definitely at the level that makes sense to our participants.
Great, thank you so much. And I don't see any more. Liz, I'm scrolling through now. Do you see anything that we've missed?
No, that's okay. I think we've answered them, and we're at time. So I think we're gonna pass this off to Sharina.
Hi, everyone. I would just really like to thank all of our panelists today, Liz, Frances, Darlene, Laura, and Elizabeth, for very engaging content and question and answer sessions. So we really appreciate your time that you spent on this session today. And I'm just going to, if you can slide over to the next 2 slides. And the contact information for all of our panelists is available in the PDF version of the slides that were available in the handout section of this webinar. So you can follow up offline with any of the panelists and get some more information, and if you have any additional questions for them, please feel free to reach out directly. And you can also send your questions to me, Sharina Hagins, if you want me to pass your questions along that way. And I'm going to pop my information into the chat box too. Next slide. There is a very, very brief evaluation that we really appreciate everybody taking the time to do, and fill that out right after the session is over. It will be emailed to all the participants as well. I also just wanted to flag that we usually have associated office hours the week after our virtual trainings. However, next week falls on the same day as the P&I, the NAC P&I, and we've just canceled our session for next week to accommodate those attending NAC P&I. If you are attending, we would love to connect with you. A lot of us are going to be there, so if you would like to offline with us and let us know that you're going to be there and touch base, that would be great. Next slide. And I just wanted to flag that our next training is going to be the part 2 of this Pathways to Cross-Sector Partnerships, and it will be presented by my organization, the National Center for Medical Legal Partnership, and our NCA peer at the School-Based Health Alliance. And I'm going to go ahead and pop in the chat box the sign up for that, so you can go ahead and get registered if you are interested in joining us for that session. And that's about it. You can go ahead and pop it on the last slide. We just would like to thank everybody again, all of our panelists and all the attendees today, for really engaging discussion. We appreciate all the questions that you sent to us and staying on the webinar, and we appreciate you filling out that evaluation. And we'll see you in April. Thank you.